We have Peggy Lavin, who's joining us today. She's an LCSW and Director of Behavioral Health for Accreditation Gurus. I met Peggy many years ago at the Joint Commission, and we really value her insight and her teams. They have representatives all throughout the country that help behavioral health as well as other facilities in their accreditation needs. She's going to provide insights into treatment planning standards. And so let's begin. We're going to start with myself and Peggy, and then we're going to move on to Maria. Peggy, so what are some of the current treatment planning standards that the accreditation agency have mandated?
Well, first, thank you for asking me to join today's webinar. Always happy to talk about accreditation. Your question, current treatment planning standards mandated by accrediting bodies such as the Joint Commission, CARF International, and also good practices such as ASAM criteria consistently emphasize that a treatment plan needs to be individualized and person-centered, patient-centered. That means the plan needs to reflect information and planning specific to each person served. The current standards also mandate that the person served needs to participate in their entire treatment experience. Assessment, treatment planning review, discharge planning. Accreditation standards provide a framework for a treatment plan, and there are required components. Needs, what are the issues that's preventing a person from reaching their desired functioning? Each identified need needs a goal, and a goal is a high-level outcome, treatment outcome, because it's high level. The standards require that each goal be broken down into objectives, and they require that the objectives be measurable, that they be indicators of progress, and that there be an anticipated time frame for the person to achieve their goal. Another required component and an important component is a listing of interventions and services. So this is any and all activities, actions provided by the organization in which the person will participate to reach their goal. Individual, family, group therapy, if it's medication-assisted treatment, the prescription administration of medication. The standards also require that the interventions and services identify the frequency of each activity and action. I would mention that the standards require that the plan is relevant at all times. So it always has to reflect the current circumstances and conditions of the person. There's the initial treatment plan, and then as it's implemented, the treatment plan needs to indicate the person's response to treatment, their progress. Joint Commission has a standard that says the use of a standardized tool or instrument to monitor the person's progress in achieving their goals must be used. So if it has to do with depression, some standardized instrument that measures what is the level of depression at the beginning of treatment and how treatment impacts that measurement. And finally, I would say the treatment plan needs to clearly indicate that the person served has participated in the planning and is in agreement with the plan. Clear indicator.
Great. Well, that's quite a bit that you covered, Peggy. And one of the ones that you mentioned, and we get a lot of questions on, and there were questions that came in, was in regard to assessments, which you mentioned, and being a critical piece of effective care. Why are these tools being highlighted so prominently in the current standards? Is this a change, or is this something that has been evolving?
I would say it's been evolving. Accreditation standards have always required that treatment plans be based on assessment findings. So that process is a very critical component to effective care. A comprehensive assessment will accurately identify the needs of the person served. And it's been evolving in the sense that are emphasizing, and one example is more the participation of the person served. So and they're using adjectives like active, collaborative participation, which, action type adjectives. And in the assessment process, that is shown by the person being actively and collaboratively involved in identifying their own needs and also their strengths, their abilities, their preferences. And that information, as well as other assessment findings, need to be reflected in the treatment plan. Evolving because CARF and Joint Commission, the accrediting bodies, are looking for outcome measurement. You know, it's how effective is this treatment? As I mentioned, the Joint Commission is even asking that a standardized tool be used to measure the effectiveness of each person's progress in treatment.
Great, thank you, Peggy, on that. So
You're
let's
welcome.
talk a little bit deeper about the master treatment plans and engaging a care team, as you mentioned, and who needs to be engaged. What are the expectations?
Well, the simple answer, Coletta, is that everyone involved in the treatment process and the treatment review process needs to be involved. Everyone that's providing assessment, interventions, and services. You asked who needs to be involved. So it does depend on the level of care. So if you have a person who's going maybe twice a month for outpatient counseling, there's the counselor, there's the therapist. But once you go into more intensive levels of care, the numbers start increasing. So you may have multiple counselors or therapists doing individual, family, group therapy. You may have someone involved in like in a residential level of care, the physical health care needs of the person. If it's medication-assisted treatment, someone prescribing, administering medication. Residential may have a dietitian. The standards say that when there is more than one, that they're all working together, that they're communicating, they're collaborating, they're coordinating treatment. Remember, it's person-centered, so everything needs to be directed directly to the person served.
Towards the individual. Okay, makes sense. Peggy, standards seem to place a strong emphasis on that patient collaboration component you mentioned. Can you share more about how treatment planning has shifted to include the patient more actively in this process?
Yeah. Well, that's exactly right. The active and collaborative participation is emphasized by the accrediting bodies for sure, Coletta. I've mentioned the type of participation in the assessment process. I gave 2 examples. In the treatment process, the standards say, and this shows the participation, that the person's own words and ideas need to formulate the goals and objectives. CARF has a standard that if there is a need for a more clinical goal, okay, but it has to be understandable to the person served. So people need to watch what clinical terminology they're using. It has to be very understandable to anyone reading the treatment plan, but most importantly to the person that is being served, the individual served.
Interesting.
Yeah.
That is very interesting, and it certainly makes sense. So for centers aiming to implement these standards successfully, challenges are bound to arise, right, Peggy?
Yes.
What are some of the common obstacles, and what advice would you give to help centers overcome them, if you can think of any?
Well, I have thought about this and also asked our consultants and some of what they see when they're working with organizations to prepare for accreditation or reaccreditation. One is that people seem to be challenged with the measurability of the objectives, and that is a requirement. So perhaps an example might illustrate that well. The goal may be sobriety. A measurable objective might be the person identifies 2 or 3 triggers that lead them to drink or use drugs. Another example, a person identifies 2 coping skills that they can start using to when they're triggered or to prevent a trigger. Might be a coping skill that's worked well for them in the past. It might be coping skill that they learn in an individual or group sessions provided by the provider. So measurability is a challenge at times. Another example that we see is and I think I mentioned, the treatment plan has to be reviewed periodically and it has to stay current. and organizations seem to do very well in the periodic review. So they have an initial treatment plan, and maybe their policy says every month or every other month for a halfway house, they're reviewing the treatment plan. And they're doing pretty well at that. That's happening pretty well. It's scheduled. But sometimes our consultants are seeing in progress notes that there has been a rather significant change in condition or circumstances of the person, and it's not considered in the treatment planning review. There's not a treatment plan review to say, okay, this might mean a different need. It might mean that the treatment plan needs to be changed, because it always has to reflect the current condition and circumstances of the person. And the last challenge I would mention that our consultants see is that I said in the assessment process, there's an identification of needs by the individual and by help with the provider. And all of those needs are expected to have a goal. But sometimes we're seeing that there's a missing need, a missing goal. And that can't happen. All the needs have to be mentioned or addressed. But it could be that that need is being referred to an external provider for treatment during that episode or after discharge. Perfectly okay, but it needs to say that in the plan. It can't be missing. It needs to state this is being referred. So those are some of the challenges I thought about and thought worth mentioning today.
No, that's great, Peggy. And it all circles completely around to that entire care team approach.
Yes.
Making sure that you've got the whole team involved. So as your example highly emphasized, if a clinician is seeing something and is documented in a progress note, something that's changed, having them part of that care team and having that ability to, in a review, have them share that so a treatment plan can be updated. Invaluable. And it really makes sense, the evolution towards a whole care team approach, not just one individual taking care of it. I think it's great. And thank you for those insights, Peggy, and updated standards. I'm sure there is more to come. And, emphasizing, as your team does, on that patient-centered, the outcome-driven care. It's clear that these standards are not just for compliance. It's really about delivering a better outcome for the individuals.
Exactly, Coletta. Individualization and engagement of the patient, the person served, means they'll be more engaged. They'll have more ownership of their treatment, and that contributes to better clinical outcomes.
Yeah, it's wonderful. I mean, we have seen with the many facilities that we serve, the evidence-based assessments that they're discovering, that are research-based, that they want to utilize, whether they're serving youth, whether they're serving substance use disorder or mental health. There really are some wonderful evidence-based assessments out there and standards, many of them very common, and many are using the same ones, but other ones that are being utilized as well. So it's great.
And evidence-based interventions and services.
Yeah, there you go.
Hand in hand with assessment.
Yeah, of great value for sure. Peggy, one of the first questions was in regard to increased compliance and personalizing those treatment plans. If you want to summarize, you really hit upon it, earlier on the entire care team and engaging the patient, I think.
Sure. So some of the suggested ways to increase compliance, let me start with personalizing the plan. I hope I've emphasized that the active and collaborative participation of the person served throughout their experience is critical and will certainly personalize a plan. I gave some examples how to do that in the assessment process, how to do that in the treatment planning process. I would also say make sure that your procedures and protocols regarding treatment planning cover the applicable treatment planning standards, that your staff know your approved protocols and procedures, and they're using them, and that you're getting the results that you intended. You mentioned, Coletta, and this is excellent, evidence-based tools during the assessment process and during the treatment process. certainly increase compliance. And because you're monitoring an individual's progress, it adds to the individualization of the plan. And as Maria just demonstrated, leverage technology to assist you for efficiency and compliance. Sometimes the people doing the interventions say, I don't have time. So you have to leverage technology to assist them to be efficient with their time. So those are some of the suggestions I would have.
Great, thank you, Peggy.
Mhm.
Maria, you mentioned terminology, interdisciplinary team, IDT, that meeting approach, and I think Peggy with the whole care team approach as well. The master treatment plan seems to allow for that seamless collaboration. Now, what if they have an external provider? And I think, Peggy, you mentioned there are some external providers or consultants. If they were authorized to access AZZLY, could they document in this master treatment plan as well, if they were to use an external provider?
They would actually have the flexibility of either situation, Coletta. So if the external provider were authorized to view the entire treatment plan, to view all needs, then they would absolutely be able to. However, they would also be able to create their own treatment plan if needed for that for that external provider, so that if that external provider needed to create their own set of needs and goals for that patient, then they would be able to do so as well.
Okay, great. Peggy, you made mention of, I think, living document and the importance of a living document to treat an individual during their episode of care. How important is that quote unquote living document?
Well, if you want to be in compliance with accreditation standards, it's critical. You can't create a treatment plan after the assessment and then let it stand without any changes or updating or revision for the whole treatment episode, because it's required that it reflects the current circumstances and conditions, and it has to, at a minimum, show the response and progress of a person. So even if there's no significant changes in condition or circumstances, there is either progress or lack of progress, as Maria mentioned. So it's a living document. It's a real-time document. It just isn't a stagnant initial treatment plan that sits there. It's got to be relevant, and it's got to maintain relevancy to the current condition and circumstances.
Peggy, this one's in regard to the differences between goals, objectives, and needs. Can you distinguish those?
Sure. I think I mentioned this a little bit when I was talking. Needs are the issues that's preventing the person from achieving their desired functioning. So it could be, I'm drinking too much. I have problems with relationships, family relationships, significant others. And I don't want to be like that. I want to have friends. I want to have a girlfriend. I want to have a job. I want my family to invite me to Thanksgiving dinner. So needs are, what the person identifies as the reasons for seeking treatment. Goals are very broad, high level, and Maria has done a great job at showing us some that she's put into the system. Very high level, and because they're high level outcomes, a treatment plan should give the person specific steps to take to reach that goal. So the objectives break down the goal into specific steps. And I gave you an example. I hope that was helpful. And I did state, and I want to emphasize this, interventions and services, it's any and all intervention and services. So if the person has some kind of physical health need and their blood pressure is going to be monitored daily, if they have some type of special dietary need, and I'm using non-behavioral health care examples because sometimes the organizations are doing a great job with the behavioral health care needs, goals, objectives, interventions, but not putting in the other activities and actions that they're taking in regards to the person, particularly their physical health needs.
Okay, great. Thank you, Peggy. Great detail. Maria,